Thank you very much, Bill, for the introduction. And the title of my talk, if I can figure out how to get this full screen, is Common Ground. And I think that a surprise, and I hope by the end of what I'm saying, you may understand and agree that, oh, perfect, there we go, thanks. That there's a whole lot more agreement between us and the positions that Scott articulated at PMS than might first appear. I think there's just a ton of common ground. I want to disclose that I'm on the ABIM and we don't share exam questions, and I mention this every presentation I give because people ask about that. The outline of the brief presentation: why are there boards? Where did they come from? Who's on the boards today? What recent changes have we made? What's the history of MOC, components of MOC? How does being an MOC help you be a better doctor? Where does the money come from and where does it go? Because we get asked that a lot. Let me say at the very beginning that ABIM was created in 1936 by a joint action of the AMA and the ACP. It was physician membership societies that created the ABIM. And they did it because they had a desire to set standards for their profession and to distinguish internists from people who claim to be internists, and maybe they were and maybe they weren't. So membership organizations giving birth to standard-setting organizations is where the ABIM comes from. And it turns out when you get medical societies, one of the first things that they do is talk about how they're going to protect the public by assuring fitness to practice among colleagues. I'm struck by Litchfield County, Connecticut, where in 1779 they proposed to examine every candidate for practice within this county or foreigner coming into the county. So when you get medical societies, one of the first things people start talking about is how do we know that people who are doing this actually know what they're doing? College of Physicians here in Philadelphia, 1787, the oldest continuous medical organization. I think they aspired to actually set a national standard for physician practice. We didn't go that way in this country. We wound up doing it at the state basis. But the founding documents from the College of Physicians, which are really interesting and talk about how we have different diseases here, so we need different cures. But that last line, cultivating order and uniformity in the practice of physic. So there is a very close relationship between professional societies and the desire to be setting standards for practice within care. The Massachusetts Act of 1649, the earliest thing I could find in this, said you had to be competent before you could get a license. And that created the problem that is still with us today. How the heck do you know who's competent? How are you able to say who knows what they're doing? How do you create a world in which people don't just stand up and self-declare, oh, I cure cancer here? And that's a conversation that begins in medical societies. The AMA actually is having that conversation in the 1840s and flowers in the board movement in the 20th century. And this was sort of what's before the AMA, and before we have that, this is New York in 1757, no candidates are either examined or licensed or even sworn to fair practice. Any man at his pleasure sets up for physician, apothecary, and surgeon. Now we act like that world is remote and distant and done, but trust me, folks, with the web out there and the internet's a jungle and you can claim anything you want, the idea that we would have a professionally determined credential that we determine as professionals is more important than ever. One of the things that's told about ABIM is somehow they're different from everybody else. They don't have anything in common with any of the people in this room. Well, as Bill told you, I practiced for 30 years in the community in which I lived in Philadelphia. Before that, I practiced for a few years in rural Tennessee in a community health center. Our board chair was chief of oncology at Vanderbilt, Dave Johnson. Clarence Bredek, our chair-elect, was a practicing general internist and teacher at UCSF and at the University of Washington. He was involved in the ACP Ethics Committee. Pat Connolly sees patients at Kaiser and is a medical director at Kaiser. Stu Linus is a practicing nephrologist at the University of Colorado. These are some of our other directors. I'm not going to go through all of them, but I will make the observation, and you all know this looking at your membership, that it's harder and harder to find the difference, the bright line between the community doctor and the doctor who's practicing in a healthcare system or an academic teaching hospital. The critical issue is people being engaged in patient care, and pretty much everybody on our board is engaged in patient care or has at some phase in their career been very engaged in patient care, as I was. We have two public members now, Sonia Madison, who's a former CEO at Health Partners, and Deborah Ness, who's the head of the National Partnership on Women and Families. These are people who bring a different perspective to the board than a group of internists might bring. And just to show that it really is one world, and I showed this to Steve the other day when we were meeting, these are people who were on the ABIM and ascended to presidency of the American College of Physicians. It's the same community, it always has been, and it still is today. And in a way that I'm going to explain in a minute, we've reorganized our work to create subspecialty boards that are more robust than before. Many of you will recognize names on this list. Yul Edgeness, the former president of ACP, full-time practitioner in Rhode Island. People like Roger Bush, who's been involved at Virginia Mason and a pioneer in some general internal medicine education. Chuck Kylo, who worked with IHI on the idealized design of clinical office practice and founded Greenfield Health Associates on the West Coast. This is probably the most substantive slide I'm going to show you about the way we've changed in terms of how we do our work. On the bottom is the board of directors, which a year and a half ago was 29 people, and the board underwent a governance redesign on this model. And this one slide illustrates the substance of that governance redesign. The board now oversees what boards do. It's policy, it's strategy, it's hiring and firing the CEO, it's 14 people. That's the board. They have delegated to the council assessment, and the council is 18 people and includes people with expertise in performance measurement, includes people with expertise in training, includes people with expertise in assessment generally. And the council oversees subspecialty boards, and each discipline now has a subspecialty board that oversees all of the components of activity within that discipline. So the secure exam, which was the only thing that the boards did before the governance redesign, now the specialty boards are engaged in society relations, they're overseeing training, and they're also engaged in part 2 and part 4 being the performance assessment work. And I think that's probably a place where we do disagree with the Pennsylvania Medical Society in saying that that should go away, and I will explain why. History of MOC, none of the boards created after 1975 had lifetime certificates. Emergency medicine never had it. Family medicine never had it. In the 80s, ABIM offered voluntary recertification. Nobody signed up. 1990, ABIM put in place time-limited certification, and the certificates issued between 1990 and 2013 were all time-limited. In January of 2014, we went to a more continuous process, so it wasn't that for 10 years you were certified and maybe you did something, maybe you didn't. Over the course of the 10 years, people are engaged. And one of the things I hear from people is we're really busy and we got a lot of things competing for our time, and we got kids to raise and church to go to, and would like to get a little leisure time in there too. And a structure that gives you a way to know that you're keeping up can be a major asset. I first recertified in 1998 before I had anything to do with ABIM when I was practicing at Greenhouse. I was a community doctor. I was not in an academic health center. I'd spent a lot of time learning something else. I really didn't know whether I knew what I needed to know to do what I was doing. I was taking care of friends, neighbors, colleagues, and I didn't have a way to say, am I on my game? Should I be doing this? Do I know what I'm doing? And in 1998, when I sat for the exam, that really helped me do that. There are 4 components of MOC: professionalism, part 1, which largely today is unrestricted license to practice. There's lifelong learning self-assessment. Think of that as CME, and increasingly at ABIM, CME will count for that. There's the secure examination. The word secure there means, do we know that the person taking the test is the person we think it is? And does everybody taking the test have access to the same level of resources? Those are the 2 constraints that drive you to a secure exam. To give a fair exam, you want to be sure that everybody has the same resources, and you want to be sure that the person taking it, on whom you're conferring the certificate, is the person taking it. Self-assessment of practice, part 4, patient voice and patient safety are are parts of 2015 ABMS MOC standards. Why do we need certification in MOC? Well, first of all, knowledge and practice change dramatically. Here's a question from the 1936 exam, and we have some people with gray hair in the room. Anybody feel real comfortable discussing the general principles and sources of error involved in the Wassermann reaction? Is that what we expect from internists in 2014? Knowledge changes fast, and it's changing even faster. And we need to have a framework in which that knowledge assessment supports physicians doing what they're doing, represents to them, their colleagues, and the public that they did it. People are asking, where did Part 4 come from? And PMS is now on record as opposing it. Well, could it be the IOM Crossing the Quality Chasm report in 2001 that said there were 98,000 deaths in this country that didn't need to happen every year, one jumbo jet a week? Could it be Beth McGlynn's paper, seminal paper in the New England Journal, about how often do people get the care that everybody agrees they're supposed to get, and finds it's about 55% of the time? Let's face it, folks, there's a growing awareness that as a healthcare delivery system, we don't reliably translate our intention into reality and into practice. We don't translate knowledge into what we do. The physician response to this is to get good at improvement, to get good at practice assessment and improvement. That's about numerator-denominator data. Numerator-denominator data used to only be available in a study context where somebody paid a research assistant to pull a bunch of paper charts and count up who had what for the numerator and who didn't have what for the denominator and create something that would then be published. We may not be living in this world of IT in our practices today, but I guarantee we will be. IT will produce the consistent availability of numerator-denominator data about how well we are achieving our goals. It's the difference between knowing who needs a mammogram and what percentage of the people you saw last year who should have gotten one actually got one. We didn't train in that. We don't know how to think about that. That's a new skill. That's as new as the changes in the way that we've moved from the Wassermann reaction, and that's what Part 4 is all about. And as physicians, I think we should be embracing it. Patient voice, patient safety. We know we're not running a safe healthcare system. We know there's lots of errors that we're committing on a daily basis. Physicians have a role in that. And increasingly, we're living in a world where people say, we really want to care about outcomes. Outcomes are produced by teams, technology, organization of care, and individual physician skills are not going to be highlighted in that world. The board credential is the credential that focuses on the skills that the individual physician brings to this very complicated world. People say, where's the evidence? Here's some evidence from our evidence library. It's across multiple years. It deals with process measures in diabetes being improved, better rates of chronic and preventive care. You're going to see some studies coming out within the next week or so that will be, I think, a pretty interesting paper on the impact of MOC. And we just had a paper come out yesterday in JAMA IM looking at the patient websites that people go to, Yelp and Healthgrades, and comparing the ratings of doctors on those websites to their clinical performance on the practice improvement modules, and demonstrating, surprise, surprise, that if you were using Healthgrades to pick your doctor, you're not going to reliably pick a doctor who's delivering good performance. It's important that we control this credential. So I'm going to close talking about the money. These are the fees. It's less than I'm paying for my Pennsylvania license. It's less than I'm paying for the privilege of prescribing narcotics to the federal DEA. On an annual basis, that's what it is. And starting in January, it moved to annually. Where does the money come from? There on the right side, 100% of the money comes from doctors. That's what professional self-regulation looks like. It's not industry money, it's not government money, it's money coming from physicians. And where does it go? This is an interactive graphic you can find on our website. If you're going to deliver exams across the country, you're going to need to partner with somebody who runs exam centers and has a computer framework that you can deliver the exam on, and can give somebody an exam when they're called into theater in Afghanistan. And that's happened, and we did it with our partner Pearson VUE. The exams don't come from nowhere. If anybody took an ABIM exam, it's a challenging exam where the wrong answers are not obvious. That turns out to be the hardest thing in an exam. We spend 14% of our budget on exam development. spend 15% of our budget on physician support and outreach. We're transparent about where that money comes from and where that money goes. And I'm going to stop here and turn it over to Chuck. But I want to close by saying I really think there's a lot more common ground than you realize. There's common ground historically. There's common ground aspirationally. It is hard to do this work. Physicians are doing it. We've positioned ourselves to get more and more physicians engaged in it and do it more and more in partnership with organized medicine. Thanks for your time, and look forward to hearing what Chuck has to say.